underwent ankle fusion or arthrodesis for hemophilic ankle arthropathy. There is quite a variation in the literature on the most commonly affected joints for hemophilic arthropathy, but there is a recent study that shows the ankle joint is most commonly affected, while a few studies have reported the knee joint has been the most commonly affected. So we felt this was important to provide useful information to both surgeons and patients. The primary outcome measures for this systematic review were preoperative blood loss, union rates, either clinical and radiological, a combination of both, postoperative complications, and length of hospital stay. The secondary outcome measures were hind-foot functional outcome scores and the visual analog pain scale score. For our methods, we adhere to the PRISMA guidelines, and the databases that were searched were PubMed, Medline, Embase, and the Cochrane Register, all from inception up until October 9th, 2022. Study quality appraisal was, we used the Minors criteria, and we used the Robin-Swan, which is the risk of bias in non-randomized studies of intervention for the interventional studies. For our inclusion criteria, we included only human studies in hemophilia A and B, patients with von Willebrand's disease, or studies that had a mix of both, where we could not clearly delineate data for the hemophilia cohort. We excluded those studies. Cadaveric studies were excluded also. Any study with a mean postoperative follow-up of less than 1 year was also excluded. And like I mentioned in my previous presentation, if there was multiple injuries in the setting of polytrauma, or if the patient had an ipsilateral surgery of the knee or hip in addition to the ankle fusion surgery, those studies were excluded. This slide shows our PRISMA flow chart summarizing the study identification, screen, and inclusion methodology. For the databases, we identified 946 studies, with 139 from Medline, 637 from Embase, and 83 from PubMed. We also identified additional 87 studies from the Journals and Ovid database, and the Cochrane Register gave us 5 studies. When we did in-text citation searching, we found 1 additional study. Following study duplication, exclusion, and final screening, we identified 52 studies, and we screened the full text articles for eligibility. We excluded 9 articles that we could not retrieve the full text articles. We also excluded 1 letter to the editor. We excluded 21 studies that had the wrong population, 4 studies that had wrong outcome data, and 3 studies that had a wrong study design. So in total, we identified 17 eligible studies that were included into this systematic review. For the patient characteristics, the mean age of the patients across the 17 studies was 37.6, with a standard deviation of 10. And a total of 271 ankle fusions were performed across the 17 studies. The most common fusion technique was utilization of the cross screw fixation technique, usually with at least 2 screws. And this was reported in 150 ankles. Looking at our primary outcome measures, preoperative blood transfusion was not reported in most of the studies, so we did not analyze for this. The pooled union rate was 71.5 to 100% at 3 months. 1 study extended up to 6 months, but for the other 16 studies, most of them reported union rates within 3 months. The pooled postoperative complication rates across 17 studies was 13.7%, while a revision rate of 6.5% was found. The range of length of hospital stay reported across the 17 studies was 1.8 to 10.6 days. Looking at our secondary outcome measures, most studies reported on the LFAS hindfoot functional outcome score. And the mean preoperative LFAS score was 35 with a standard deviation of 13 across 40 ankle fusion procedures. So it means not all studies reported outcome data using LFAS scores. So 40 ankle fusion procedures were reported using the LFAS scoring system. For the postoperative mean LFAS score, for 63 ankle fusions, the mean score was 79 with a standard deviation of 5. So it means there was an improvement because the LFAS score with a maximum of 100, the higher the score, the better the patient-reported outcome measures in terms of pain and their mobility and their alignment of the hind foot and all that. For the visual analog pain score, the mean preoperative VAS was 6.3 with a standard deviation of 1.6, while the mean postoperative VAS score was 0.9 with a standard deviation of 0.4 across 38 ankle fusion procedures. If we compare the results for ankle fusion in our hemophilia patient population with a study that was published looking at the short midterm outcomes of total ankle replacement in hemophilia by Asensio et al. In the Foot and Ankle Surgery Journal in 2014. So they looked at, it was a retrospective study, not a summary review. They looked at 21 patients with hemophilic arthropathy. And for their patients, 32 patients had total ankle replacement. And they found an alpha score improvement from 40 preoperatively to 85.3 postoperatively. And also notice that 2 patients out of their the 21 patient group went on to have further surgery, which was an ankle arthrodesis. So it appears that ankle arthrodesis was used as a salvage procedure in their own patient cohorts. If you look at the strengths of this summary review, we had a relatively large pool sample size, considering the fact that hemophilic ankle arthropathy, when compared to primary ankle osteoarthritis of the ankle, or rheumatoid arthritis, or other causes of arthritis of the ankle, the incidence of hemophilic arthropathy is low compared to these other disease pathologies. So this sample size of more than 250 is quite relatively large. We use a systematic approach, as mentioned, adhering to the PRISMA guidelines. And most of the studies had reported on long-term postoperative follow-up results. The risk of bias using the Minors and the Robbins-1 criteria across the included studies was moderate. For this study, there were 2 studies that were prospective interventional studies. The rest were retrospective studies, and there was no randomized control trial. The limitations of this study is that some of the published studies reported mixed data. What I mean is that there was no uniform reporting system. Some of them use the alpha score, some of them use other outcome scoring systems. None of the studies had an overall low risk of bias, which is not surprising because if you look at the Minors and the Robbins-1 scoring systems, most studies that are not prospective interventional and are not randomized control trials are likely to have at least a moderate risk of bias. Finally, we do not adjust for confounding factors like mortality and medical comorbidities. And unlike the initial study that I presented, we also did not analyze for viral co-infection like HIV and hepatitis B and C. The relevance of this review to clinical practice is, once again, very important information for counseling our patients on complication rates and revision rates for total ankle fusion in hemophilic arthropathy. And also the postoperative complication rates for ankle fusion for hemophilic arthropathy is quite similar to the complication rates for total ankle replacement for the same disease condition. And to give us higher quality evidence in our orthopedic surgery specialty, high quality randomized control trials are required in the future. Thank you.
Thank you, Doctor. Any questions with regards to this presentation for Dr. Fitzgerald?